The current approach to diagnosis and treatment of iron deficiency in patients with HFrEF is summarized in this slide. In symptomatic patients with heart failure with reduced EF, iron studies and hemoglobin should be checked. If hemoglobin is less than 15 and iron studies reflect iron deficiency defined by either ferritin less than 100 or 100 to 300 accompanied with TSAT less than 20%, then IV iron therapy should be considered. The ESC algorithm provides a conceptualization on the calculation of dosing in patients with HFrEF according to a patient's body weight and hemoglobin levels. For example, for a patient with a hemoglobin in the 10 to 14 range with body weight over 70 kilograms, would need approximately 1,500 milligram iron to correct the deficiency. The recommendation is to check ferritin and TSAT levels, usually after 3 months, and subsequently once or twice a year. This slide lists the contraindications and special circumstances with IV iron therapy in heart failure. IV iron should not be given to individuals with known hypersensitivity to the active substance, such as ferric carboxymaltose or any of its content, known serious hypersensitivity to other parenteral iron products, in anemia not attributed to iron deficiency or such as other circumstances of microcytic anemia, in patients with evidence of iron overload or disturbances in utilization of iron. IV iron should be used with caution in patients with acute or chronic infection. Treatment with ferric carboxymaltose should be stopped in patients with ongoing sepsis or bacteremia. Patients with known allergies, including those with history of severe asthma, eczema, or other atopic allergies, may be at an increased risk of hypersensitivity reaction. Patients with immune or autoimmune conditions such as rheumatoid arthritis or SLE may have increased risk of hypersensitivity reactions to parenteral iron complexes. Please note that currently there is no evidence for IV ferric carboxymaltose or any other IV therapies for patients with HFpEF, with LVEF greater than or equal to 50%, and there is very limited efficacy or clinical evidence for patients with HFmEF or heart failure with mid-range EF with EF between 40 to 49%. And that the efficacy and safety of IV ferric carboxymaltose has not been evaluated in patients with hemoglobin levels over 15. How should it be administered? IV iron can be administered in the hospital or community setting where staff are trained and equipped to monitor for and manage hypersensitivity reactions. Patients should usually be observed for adverse effects for at least 30 minutes following each IV injection or infusion. Regarding long-term monitoring, following replacement, iron levels should be reevaluated approximately in 3 months, and further iron repletion can be provided at that point as needed. Earlier than a month of iron status, let's say within 4 weeks, should be avoided as ferritin levels will increase markedly following IV iron administration. Evaluation of iron status can be part of routine in patients with known heart failure about once or twice a year or when symptoms remain.